Number 1. Wrong baby teeth, 2013. The case began as a routine dental visit. A 4th grade boy was brought in by his grandfather for a standard checkup. Nothing more serious than cleaning or a cavity check. In the same clinic, another child was scheduled for a full mouth extraction due to severe dental disease. Their charts were mixed up, and the boy who needed only a routine visit was mistakenly prepped for the major procedure. After sedation, the dentist began working through the extraction plan tooth by tooth, because none of the teeth were loosened or diseased. Removing them required prying each one from the gums using elevators and forceps. The gums tore as the teeth were twisted free, and suction had to be used repeatedly as blood filled the mouth. By the time anyone realized the chart error, all 20 baby teeth had been removed. When the boy woke up, his entire mouth was packed with gauze. His gums were raw, swollen, and bleeding in every socket. Eating or even swallowing was painful, and he had to stay on liquid and soft foods for an extended period. Healing was slow because every area of the mouth had been disturbed at once. Beyond the immediate trauma, removing every baby tooth prematurely can affect jaw development, speech, and eruption of adult teeth. The child needed repeated follow-ups and long-term monitoring just to ensure his mouth could develop properly. The dental office later admitted the mistake, explaining that the incorrect chart had been pulled and confirmed several times without anyone realizing it belonged to a different child. Number 2. C-section gone wrong. During a C-section in 1999, a woman underwent a routine delivery that appeared to go smoothly. The surgical team used a variety of tools, including a long metal retractor, designed to hold back tissue and improve visibility inside the abdomen. After the baby was delivered and the incision was closed, the staff performed a standard instrument count, but the count was recorded incorrectly. The retractor, measuring roughly 13 inches, remained inside the patient's abdominal cavity. Because it was long and flat, it settled between loops of intestine without causing immediate complications. The woman went home unaware that a large surgical tool was still in her body. For months, she experienced persistent abdominal pain, swelling, and difficulty standing straight. Doctors initially assumed it was normal post-C-section recovery or digestive issues. Pain medication and rest didn't help. It wasn't until she insisted on further examination that imaging was done, and the X-ray revealed the outline of the entire metal retractor inside her abdomen. The surgical removal required reopening the abdomen wall and carefully navigating around scar tissue that had already formed around the tool. The retractor had created pressure against the intestines, leading to inflammation and risk of long-term complications. Leaving instruments inside patients is a known surgical error, but a tool of this size being missed is extremely rare. The hospital investigation later identified mistakes in the instrument count, a failure to follow standardized checklist protocols, and poor communication between staff members. The woman required an extensive recovery after the second surgery to undo an error that should have never happened. Number 3. Wrong side brain surgery. At Rhode Island Hospital in 2007, a patient was scheduled for a procedure to relieve pressure from a brain bleed. The imaging clearly showed the bleed on one side of the brain, but failures to communicate and chart review led the surgical team to operate on the opposite side. Before the operation, the patient was prepped with the incision site marked incorrectly, the surgical pause. The step where the team confirms the procedure, location, and patient details was rushed and done verbally, without checking the scan on the monitor. The surgeon relied on a handwritten note instead of the imaging. Once anesthesia took effect, the team shaved the scalp on the wrong side, cleaned the area, and made the incision. A burn hole was drilled through healthy tissue. Only after opening the skull did a staff member review the scan again and realize that the blood clot was on the opposite side. The mistake was brought to the surgeon's attention, mid-procedure, but the damage from drilling in the wrong side had already been done. The operation had to be stopped, and a second team later performed the correct surgery. The patient suffered complications, including further bleeding and swelling, which contributed to a decline in condition. This wasn't an isolated incident. Rhode Island Hospital had multiple wrong side brain surgeries in the same year. 3 documented cases, prompting investigation at the state and federal level. The errors were traced to miscommunication, improper verification procedures, and staff fatigue. The hospital was fined and required to overhaul its surgical procedures. Number 4. Fertility clinic mix-up. In 2019, a Los Angeles fertility clinic made one of the most widely reported reproductive errors in recent history. A woman undergoing in vitro fertilization was implanted with what she believed were her own embryos. The pregnancy progressed normally and she attended all standard checkups. Ultrasound showed a healthy fetus, and nothing appeared unusual. The confusion began at birth. The newborn's physical features did not match either parent, not in complexion, not in facial structure. At first, the clinic suggested it might be a quirk of genetics or recessive traits, but DNA testing was ordered, and results confirmed that the truth. The baby was not biologically related to the woman or her husband. The embryo belonged to another couple being treated at the same clinic. Further investigation revealed the error happened during the fertilization and labeling phase. Embryos from different couples had been mislabeled, and one of the clinic's technicians transferred the wrong embryo into the patient. The mistake wasn't caught because multiple steps of the verification process were skipped or performed incorrectly. After delivery, the baby had to be turned over to the biological parents. The woman who carried him for 9 months was legally considered a gestational carrier despite never intending to be one. The emotional shock extended to all 3 families involved. The case led to lawsuits, the shutdown of portions of the clinic's operations, and nationwide scrutiny of IFV safety standards. It remains one of the clearest examples of how a labeling error in a fertility lab can completely alter the outcomes of multiple families at once. Number 5. Willie King. Willie King went into Tampa's University Community Hospital in 1995 for surgery on his infected right leg, which needed to be partially removed. Somewhere between the paperwork, the surgical schedule, and the markings placed before the procedure, the wrong leg, the left, was identified as the surgical target. The error made it all the way through prep, verification, and anesthesia without anyone stopping it. Once King was unconscious, the team began the amputation. The left leg was cleaned, draped, and secured. The surgeon made the incision through the skin and muscle, then tied off the blood vessels to minimize bleeding. The leg was removed exactly as planned, except it wasn't the leg that needed the surgery. Mid-procedure, a nurse realized the mistake after reviewing the chart again. By the time she spoke up, the operation was already too far along to reverse. King woke up hours later missing the wrong leg, while the infected right leg remained attached and still required surgery. The hospital later confirmed that multiple steps failed. The chart listed the correct leg, but an abbreviation error misled the team. The surgical schedule had been transcribed incorrectly. The limb marked before surgery was marked by staff who relied on the wrong document. Willie King eventually had the correct leg amputated too, meaning he lost both legs because of the initial mistake. The hospital paid several $1 million in settlements, and the surgeon had his license suspended for 6 months. Number 6. Lewis Blackman Case. The Lewis Blackman case is one of the clearest examples of how a chain of small medical mistakes can add up to a fatal outcome. Lewis was a healthy 15-year-old boy who underwent surgery to correct a minor chest deformity. The procedure was routine, but he was prescribed Ketorolac, a pain medication known to increase the risk of internal bleeding in post-operative patients. No attending surgeon evaluated whether it was appropriate for him. Over the next 30 hours, Lewis showed multiple signs of internal bleeding, pale skin, dropping blood pressure, severe abdominal pain, and restlessness. His mother repeatedly asked nurses to call a doctor. Several times she was told he was simply dehydrated, anxious, or reacting to the pain medication. No senior physician examined him during this period. As the bleeding worsened, Lewis's abdomen became firm and distended, a classic sign of internal hemorrhage. But it was still dismissed as normal post-operative discomfort. He was given incorrect IV fluids and treated for conditions he didn't have. His vitals continued to deteriorate, but the staff misread the severity of the numbers. Overnight, he went into shock. By the time a surgical team was finally called, Lewis's condition had passed the point of recovery. His organs were failing from blood loss that had gone untreated for more than a day. He died shortly afterward. Every step of the process had an opportunity for someone to intervene. A doctor to reevaluate, a nurse to escalate the symptoms, a supervisor to override the misdiagnosis. None of those steps happened in time. The investigation concluded that the death was fully preventable and caused by communication failures, medication errors, and lack of physician oversight. Number 7. Jessica Santillan. Jessica was a 17-year-old girl with a severe heart and lung condition. In February 2003, she was admitted to Duke University Hospital for a long-awaited heart-lung transplant. The donor organs arrived, and the surgical team proceeded with the operation. What no one realized until after the transplant was complete was that the organs were the wrong blood type. Jessica was type O. The donor organs were type A. This mismatch should have been caught immediately. Blood type is one of the most basic compatibility checks in organ transplantation, usually verified by several individuals at multiple stages, but the hospital failed to perform the final verification step. The error made it through multiple layers of review without being noticed. Once the organs were connected and blood began circulating, Jessica's immune system reacted violently. Her body recognized the new heart and lungs as foreign tissue and mounted an immediate attack. Within hours, she developed massive swelling, reduced oxygen levels, and organ dysfunction. Doctors realized the mistake only after reviewing the donor's records post-surgery and seeing the incompatible blood type. The team attempted to reverse the rejection of high-dose immunosuppressants and plasmapheresis, but the damage was already severe. A second transplant was performed in an attempt to save her, this time with compatible organs. But by then, she had suffered major brain injury and irreversible organ failure. Jessica died shortly afterward. The incident led to national scrutiny, internal investigations, and new safety protocols for transplant verification. It remains one of the most widely known and preventable fatal medical errors in U.S. history. Number 8. You said how many? One of the most extreme retained object cases ever recorded occurred in Japan in 2006. A male patient who had undergone abdominal surgery years earlier began experiencing chronic stomach pain, bloating, and fatigue that gradually worsened. Over-the-counter medication didn't help, and multiple hospital visits failed to identify the cause. Eventually, imaging tests were ordered, and the scans revealed something almost impossible to overlook. Inside his abdominal cavity were over 30 foreign objects. The items included surgical gauze, cotton pads, clamps, and often absorbent materials used to control bleeding during open procedures. Over time, the objects had shifted positions, clumped together, and became partially embedded in surrounding tissue. Some pieces had fused into scar tissue, while others had caused inflammation and pockets of infection. Retained objects occasionally happen when sponges or small tools are miscounted, but the sheer number in this case indicated a massive breakdown in surgical protocol. Standard practice requires counting every sponge and tool before and after the operation. Here, the counts were either skipped or recorded incorrectly, multiple times. The patient required a major corrective surgery. Doctors had to remove each object carefully to avoid damaging organs and blood vessels. The larger pieces came out intact, but many smaller items had to be separated from the tissues manually. The operation was long and complicated, due to the risk of rupturing the areas where infections had formed around the foreign bodies. After the removal, the patient faced a difficult recovery. Years of irritation had weakened parts of his abdominal wall and left lasting inflammation. Investigations revealed that the original surgical team had violated basic safety checks, and the hospital faced severe criticism for allowing such a large number of items to remain unnoticed for so long.